प्रेजेंट तो है ऑक्सफोर्ड में, ये इंडियन हाई कमिश्नर और पीएमओ ऑफिस आप तो जानते होंगे।
इसका एक लॉगिन पेज खुलता है, पेज नहीं खुलता,
बहुत परेशान
Practical management of osteoporosis and sarcopenia. We have with us distinguished faculty from the United Kingdom, Dr. Kaushik Chaudhary, who has joined us in person, and Professor Qasim Javed, who will join us virtually from the UK. The session will be chaired by our respected Dr. S.S. Jha, who will also present the IOA guidelines on osteoporosis and sarcopenia. I request all members to keep the program interactive and practical. Kindly keep your mobile phone on silent mode. Question may be asked during the designated question and answer and panel discussion. I now request our President, Dr. Atul Kurses, to kindly deliver the welcome address.
Good evening, respected seniors, distinguished faculty and my colleagues. On behalf of US, it is a pleasure to me to welcome all to this scientific symposium. As orthopedic surgeon, we are witnessing a growing burden of osteoporosis and osteosarcopenia, making it essential for us to remain updated with latest evidences, innovation and the treatment protocol. Today we are privileged to have with us an eminent panel of faculty. I extend the hearty welcome to Dr. S.S. Jha for sharing vast experiences in osteoporosis and metabolic bone diseases. We are also honored to welcome Dr. Kaushik Chaudhary from UK, whose international perspective will undoubtedly enrich today's deliberations. We also look forward to his participation of Professor Qasim Javed, his expertise in osteoporosis and metabolic diseases. Today's program combines expert lecture, case-based discussion and panel discussion, providing an excellent opportunity to learn from one another. I sincerely thank our faculty members, organizing team, sponsors and members of EOS whose efforts have made this academic evening possible. Once again, I warmly welcome you and wish you a stimulating, enriching and scientific session. Thank you. Again, I have a wonderful evening.
Thank you, President Sir, for your welcome address. We shall now proceed with the scientific session. I request Dr. Ashok Vij to kindly introduce our chairperson, Dr. S.H. Jha, and invite him to the dais.
To all of us, Dr. Jha is not a person who needs any introduction. We have been blessed time and again since the last more than 20 years with his presence and his scientific deliberations in Agra itself. He is the director of Harishchandra Orthopedic Research Institute, Patna. He is the advisor and expert for the IOA guidelines on osteoporosis. He has been president and patron of the Geriatric Orthopedic Society of India. He is patron-in-chief and founder-president of Indian Orthopedic Rheumatology Association, the IORA, which is in short. He's been the president of Indian Orthopedic Neurology Association, past president of Indian Foot and Ankle Society, and editor-convener of Indian Journal of Orthopedics Osteoporosis Supplements. He is a person who not only delivers the scientific content to all of us, but more than that, the vibes that you get from his aura are a blessing in itself. Welcome, Dr. Shah.
Well, thank you, Dr. Ashok, for that introduction. Friends, without wasting any time, can I have my presentation here of introduction? Introduction of the topic. So friends, we are all aware that this evening we are going to talk about osteoporosis, and not only osteoporosis, sarcopenia and the latest nomenclature. As I stand here this evening in Agra, I cannot forget and I wish to acknowledge Dr. Atul Srivastav, who I say is the president of Indian Orthopedic Association. I call this consciously because president of USA is never an ex-president of USA. So Atul, I am so very thankful to you and would like to acknowledge because you had a theme of the Indian Orthopedic Association during your tenure, strong bones and a stronger nation. Thank you, thank you. And I must thank Dr. Sarika as well because she was a member of the guideline framing team and she very actively participated. Thank you, sir. Well, friends, the theme of this evening is from fragility fracture to functional recovery and practical management of osteoporosis and sarcopenia. Well, you can look into this architecture and the whole game is of mass and architecture. So basically, all of us sitting here are conscious that osteoporosis is a skeletal disorder with compromised bone strength, and that is what predisposes to the fragility fracture. And you can look into the framework of the table on the left and the table on the right. So, the fragility fracture is determined by bone strength, and that is determined by bone mass and quality. Friends, here itself, when we are going to talk about sarcopenia, I will like to say that the muscle strength is also determined by muscle mass and muscle quality. Well, fragility fractures, all of us know, occur spontaneously or following minimal trauma, defined as fall from a standing height or less. But then, what heralds functional recovery? It is definitely the theme of the evening, including sarcopenia, of which we are very much conscious the last few years. The practical management of osteoporosis, sarcopenia and osteosarcopenia is what we are going to discuss this evening. So, of course, there is a new nomenclature that age-related loss of bone mass, quality and strength is osteopenia and osteoporosis, whereas age-related loss of muscle mass, quality and strength is what is sarcopenia. But when a person falls down, is it entirely because of a weak bone or because of weaker muscles? And these falls produces fractures with attendant morbidity, reduced quality of life. Friend, all of us are aware that there is a peak bone mass attained by the age 30. Similarly, we must be conscious that peak muscle mass is there at around the age of 25. There is a natural decline of 5% up to the age of 39 that gets converted to 8% decline from 40 to 69 and 15% in persons aged more than 90. But that here the story does not end. Additionally, up to 50% of older adults have an advanced form of muscle loss, which is known as sarcopenia, which can impact their overall health and recovery. Well, going into the pathophysiology details I will not go through, but what is most important that apart from the various factors present, the risk factors, aging, vitamin D deficiency, inflammation, metabolic dysfunction, inactivity, corticosteroid use, comorbidities, etc., there is a crosstalk for which we must be concerned, and which has been a late evolution by molecular theories pronounced and proved that the muscle mass gets decreased, muscle function gets decreased, and it is responsible for producing fracture. Similarly for the bone. But let's go into little more detail that during normal health, what happens? Mechanical loading, you can say the muscle husbands the bone. So IGF-1, FGF2 and irisin, they are responsible for bone health, whereas the bone produces OCN, PGE2 and IGF-1 and is responsible for promoting muscle protein synthesis, preserve muscle mass, maintain muscle repair. So you can say that while the muscle husbands the bone works like a child seater for the muscle. Well, muscle and bone, what happens when it is disease or aging? So you can again say that myostatin, IL-6, interleukin-7, they go and influence the bone, whereas from the bone it is various genetic factors ultimately activating UPS and FOXO genes, and muscle mass and strength get diminished. So this crosstalk continues. Well, appropriate management of osteoporosis is definitely required, and components of the fracture risk are skeletal risk factor, non-skeletal risk factor. Whereas pharmacological treatment of osteoporosis is well established, the spectrum of fracture risk pyramid and management, all of us are aware of this, in which in the top we have drugs like teriparatide, abaloparatide and romosozumab, and in the base there may not be even a need for pharmacological treatment. So friends, when muscle degeneration takes place with aging, there is less muscle formation and number of size of muscle fibers also get diminished. There are three things which are very common pathways of muscle protein breakdown. So muscle protein breakdown is very important. There is inflammation. All of us are aware with the terminology inflammation when we talk about inflammation in aged persons. So here also in inflamed muscles there is inflammation, and there are changes at mitochondrial level. Are these changes reversible or irreversible? Can it be reversed? And can muscle loss be treated by oral therapy? So all these things are going to be discussed in greater detail by none else by Dr. M. Qasim Zaved, who is Professor of Osteoporosis and Adult Rare Bone Diseases, University of Oxford, Honorary Consultant Adult Rheumatologist at Oxford University Hospital, NHS Foundation Trust. He specializes in common and rare metabolic bone diseases. He is clinical lead for the National Fracture Liaison Service Audit for England and Wales, the Oxford Rare Bone Diseases Services for Adults, and co-chairs Rare Disease Collaborative Network for Adult Rare Diseases. His research interests include the epidemiology of rare bone disorders and secondary fracture prevention. With these words, we unfortunately could not have you here physically, but that you are virtually present, I welcome you, and now the whole subject is open for the discussion. Thank you.
Oh, hi, Kelsey.
Very warm welcome to Agra. 35 degrees in the shade, so there you go. all yours.
Full screen कर दो.
That's the work option there.
हाँ full screen.
Can you see my sheet, my slides, Kelsey?
We can, yes. Thank you. We can see the title slide.
Perfect. Great. I can't see. Yeah, I can see the slides. Great. Well, thank you so much for the extremely kind invitation. I'm very sorry I can't be there in person. Ideally, I would have already seen the Taj Mahal with Kaushik and we'd have had a lovely day together. But it's a real pleasure and an honour really to come and share with you some insights around osteoporosis and on next steps going forward. Kaushik, can you hear me okay?
Loud and clear.
Brilliant. Okay, I'll crack on then. So here are my disclosures. So I'll go through what's a bit new on fracture risk assessment, anabolics. I missed Professor Shetzar's opener on sarcopenia, but I'll touch on that and then I'll finish with the unmet need. So we're all in this room because we love bone. Bone is one of the most, well, in my humble opinion, the most important structure in the body. Without it, everything falls apart, literally. And we are aware of the beautiful mechanics, but also increasingly aware of the endocrine and other regulatory processes that bone has. One major insight that we've had over the last decade is that although we're very good at measuring the trabecular component of bone, actually we struggle to measure the cortical component. The cortex of a step.
Kaz, you're not audible.
Microphone.
I thought
Yep. Try again. We can't hear you.
Not our microphone.
Yeah, so
His
that's
microphone.
working. Your microphone may be on mute. Yeah.
Eco group का है ना चंदन.
जी sir. Briefly we heard a hum.
एक बार Zoom की मैं साउंड टेस्ट कर लूँ सर यहाँ से.
Oh, wonderful.
Thank you.
Okay, I'll just go back a bit. I'll run through these matters. So we're all here because we love bone, and one of the major insights that we've had in the last decade is that while we're very good at measuring the trabecular component of bone, actually the cortical porosity is much more difficult to measure. Kaushik, can you hear me okay?
Loud and clear. Go
स्क्रीन आप
ahead.
कॉपी कर रहे हो ना फिर लाइट बंद.
Thumbs up if you can hear me.
You can't see me, but we can hear you.
Can you hear me?
Yep. Yes.
Can you hear me, Kaushik?
Yes.
स्लाइड दी है मुझे.
Yes, excellent. Okay, I'm off then. Right. So as you can see on this image, it's very important to note this because this really helps us.
You're stuck on the first mic. Yeah, go ahead. That's the yeah.
Okay. So, what's the purpose of an osteoporosis service? It's really to avoid the maximum number of fractures with the resources we have and use that to present the case to our people. Fracture risk. And that is the risk of a second fracture after we see a fracture is massively increased. And data from Iceland has clearly shown that if you have a major fracture, half of those fractures are happening in the first 2 years. Our common tool for looking at fracture risk is FRAX. We have FRAX in many countries, the UK as well as India. And actually what we have to be aware of is that FRAX generally underestimates recency. And this is quite a large difference in fracture risk. If we just take the normal FRAX for a 65-year-old woman, they may have a fracture risk of around 13% over 10 years. However, from our epidemiological data, the fracture risk for that patient over the first 2 years is not simply 13 divided by 5, but much higher. And as you can see from multiple studies across the world. And this is very important when we come to looking at fracture risk and how we identify those at very high fracture risk and the limitations of current tools. Now there are two other populations who are at very high fracture risk that we've become more aware of. We are starting to see people who are fracturing on treatment, usually oral agents. And this data shows that if you look at patients who fracture on treatment in the dark blue, compared to those with a diagnosis of osteoporosis, with a new fracture, or to just start treatment, if you have someone who's fractured on treatment, they are at the highest risk for hip fractures and major fractures. So it's really important that we take care for adults who are fracturing or are already established on treatment. And there are a number of guidelines for how to define fracture on treatment and the next steps going forward. So that's the first group. The second group is our understanding of the importance of vertebral fractures. So we call the rate of hip fractures. They have the highest reduction in fracture rate of treatment, and we know physiotherapy, painkillers, and we're indicating interventional radiology. We are not very good at finding vertebral fractures. At the moment, we're very bad in the UK system and around the world using back pain, because often many patients aren't presenting with back pain. We can sometimes use our bone density machines to find them with vertebral fracture, or we can try to find them from primary care or from radiology reports. And the reason why radiology reports are tricky is because we often see patients like this. So this is a patient with a right kidney stone who's had a CT scan, and the report has directly identified the pelvic fracture, pelvic stone, but completely missed the fact that although there's no sinister bone pathology, there are so many vertebral fractures present that this patient is at extreme risk of another fracture. Now, we have tried to work with our radiologists to try and improve how well they report vertebral fractures from CT scans. And we did this using audits in 2019 and then just after the COVID pandemic. There were lots of scans that were analysed, over 6,000 in 2019 and over 7,000 in 2022. But as you can see, even with education, it made a very small difference. And most radiologists continue not to report vertebral fractures on CT scans. And this is a really interesting area where artificial intelligence can come in. And many of you may be thinking, well, artificial intelligence is far away, or some of you may be thinking, I'm already using artificial intelligence, but there are now machines available and algorithms that can identify vertebral fractures. And this is very important given the thousands of scans that are done every year in some hospitals. So in some scans are now able to actually indicate not only is there a vertebral fracture, but also where in the spine it is. And this makes it very easy for us to then quantify if the vertebral fracture identified is true or not. And as part of a clinical study, we looked at using an algorithm where we looked at artificial intelligence rereading CT scans, but interestingly, we actually pushed the results into a fracture liaison service model, or a fracture model, to understand who needs osteoporosis treatment and then give them the right intervention. And the results have been presented in an abstract form and a paper is being submitted. But basically what we saw was adding AI to a hospital system almost triples the rate of spine fractures identified. However, this large increase in spine fractures overwhelmed the services, so all of their other key performance indicators got worse. And this really shows to be effective, if you're going to use AI, you need a very good fracture pathway. So what does a good fracture pathway look like? A good osteoporosis pathway should identify as many patients as possible, rapidly assess them, and make sure that they have the right treatment. And we call this optimal prevention using the high imminent fracture risk paradigm, where we have rapid identification, assessment, and treatment recommendation. I'll just spend a few slides now going through why treatment recommendation is so important. So we know now from a number of studies that the next fracture is very likely to be a non-vertebral fracture. So in this study from Canada, actually less than 10% of the subsequent fractures were vertebral fractures. Which means when we look at the differences between our osteoporosis treatments, we really have to focus on non-vertebral fracture. And for non-vertebral fracture, actually there is a difference between the treatments. So these are the classic anti-resorptive treatments and the results from the registration trials. I've indicated in the dotted line the separation after 12 months of treatment initiation. And you can see while there is separation, it is not very large. And this is further confirmed by a meta-analysis of the time to benefit for non-vertebral fractures. And you can see for the agents of alendronate, residuronate, and zoledronate, the amount of time in months before you can reduce non-vertebral fractures to a meaningful amount. So for zoledronate, almost 2 years of treatment to reduce non-vertebral fractures. And this is different to what we see with the anabolics. So with teriparatide compared to placebo in the NEAR study and compared to residuronate in the KENDA study, you can see clear separation by 12 months, which is very encouraging. However, because of the design of the studies, they were underpowered to detect differences in hip fractures. And you can see there were only five hip fractures in the residuronate arm and 2 hip fractures in teriparatide arm from the KENDA study. Abaloparatide is one of our newer PTH analogs. Again, it's a daily injection, this time given for 18 months or 2 years. And you can see the study included people with and without fractures, and there was a similar separation of non-vertebral fractures within 12 months. This study has also shown that the BMD responses were present at the hip, something we hadn't seen with previous PTH analogs such as teriparatide. And we now have real-world evidence where they look at 20,000 patients who have been given abaloparatide versus teriparatide to look in observational prescription data how many of them will go on to have a fracture. Because this is American data, reimbursement is a very significant problem. So actually, very few people could afford to continue the abaloparatide or the teriparatide for more than a year, with persistent rates of less than 50%. So overall, this study did show that abaloparatide was superior to teriparatide, both for hip fractures and non-hip fractures, non-spine fractures. And you can see these differences were statistically significant. However, as I've already mentioned, this was a slightly difficult study because so many people stopped their treatment. And of some note, if you only look at the people who completed more than 12 months of treatment, here you could not see a significant reduction in fractures of the hip or the non-spine, which still raises some uncertainty around differences in the larger population. So now on to romosozumab, which is our anti-sclerostin inhibitor, and this is different. Here we have large power studies for hip fractures, and you can see the reductions in non-vertebral fractures are present even at 12 months in the placebo trial, and you can see separation in non-vertebral fractures by 12 months in the trial compared to 11, showing clear superiority. And this difference between romosozumab and teriparatide probably links through to the mechanism of action. And although there's lots of discussion about the mechanism, this is best summarized by the effects on bone density. Here you can see both teriparatide in blue and romosozumab in orange increase spine bone density. But there is a very different response at the hip, with no real difference in hip bone density at 12 months, compared to a strong increase in hip bone density measured either using DEXA or cortical measures. And this difference actually accounts, we think, for most of the difference between the anabolic agents. Now, a very new study that's just come out is the LEADER study, and this study used a very different study design. Because of insights into how romosozumab works, they were able to show that 3 months of romosozumab followed by denosumab had the same BMD response as 12 months of romosozumab. And although not published, it's reported that the microarchitecture changes were not different. This is a profound impact for our community, because may lead to only 3 months of therapy, which would have big financial impacts, may have an impact on injection site burden, and also CV risk, as I'll come into. So when you put all of this together, you can actually compare how different agents reduce fractures. And this is data that we used with UCB and the team at Oxford with the health economists, where they did a simulation study looking at the refracture reduction from different agents. And what they were able to show was that the refracture reduction was low with oral bisphosphonates, and probably the same with intravenous bisphosphonates. So bisphosphonates and anti-resorptives in the people with a recent fracture are suboptimal treatments, and if possible, we should be using anabolics first. Do we have any data to back up this approach? Well, this is a woman we had in our clinic. She was 83, she had a hip fracture. As part of her pathway, she had zoledronate, but unfortunately the next year she broke her other hip. And this is very sad, because women who have, or men who have 2 hip fractures do exceptionally badly, and this is usually a very serious event. So on the one hand, we have made great improvements in the number of hip fracture patients having any treatment after their hip fracture through this 5 nations consensus paper. This paper made it very easy for orthopedic surgeons, orthogeriatricians to follow a very simple pathway to get as many patients onto treatment. And we've seen the treatment rates go up by over 50% in 2022 to 2024, just a year after the consensus guideline was produced. Well, this may be oversimplistic. So this data from Mass General Hospital asked a very simple question. If you give zoledronate or don't give zoledronate, what's the impact on patient outcomes in the real world setting? And here they're able to show something we already knew. If you give people zoledronate, they live longer. Now this may be because of some residual error, because your people who haven't been given zoledronate are usually sicker. So they did try to adjust for this using statistical methods. But they are able to show convincingly reductions in mortality in all patients after a single dose, and most in the younger hip fracture patients, but also a slight reduction in those who are aged over 90. However, the real interest came when they compared what happened in terms of fractures afterwards. As we'd expect, zoledronate significantly reduced the risk of vertebral fracture, but surprisingly, after 2 years, had no impact on non-spine or hip fractures. And this is noteworthy because we can't really explain this because of differential treatment. And this takes us back to the Lyle study, which is a randomized trial, which did actually show good separation at 2 years. So we're left in a bit of a quandary, a bit of confusion about should we really be pushing zoledronate, or actually which hip fracture patient should be worked up for anabolic first. As you know, no treatment is without risk, and we have risks for the baloparatide with very clear indications for who should not have it, as listed here, but still some confusion about what's the impact of orthostatic hypertension and ECG changes. With romosozumab, the main concern is an excess of major cardiovascular events in the romosozumab compared to an endronate study that was not seen when the study was compared to placebo. When they looked at the patients, they couldn't find any risk factor that made a difference in terms of their cardiovascular risk. So it wasn't pre-existing cholesterol, hypertension, or diabetes. What they did note was a big difference if there was previous cardiovascular disease, and so when they took out all the patients with a previous history of heart attack or stroke, they were able to substantially reduce the risk of cardiovascular risk. And this allows us to operationalize cardiovascular risk assessment in this group, so we can really focus on those who have the lowest risk of cardiovascular disease or the highest risk of fracture. Now it's very important when we think of anabolics that it's not just the drug, but the sequence. And this is some nice data that shows what happens when you use different treatment thresholds and different treatment pathways after you see a patient. So if you take a patient with a BMD score of -3.5 and give them alendronate for 3 years, then just over 10% will have a BMD above 2.5% for 3 years. So less than 20% will no longer be osteoporotic. If you give an anabolic and then alendronate, you could increase the number or proportion who are no longer osteoporotic to almost 50%, but an anabolic followed by denosumab increases to almost 70%. So sequences is important, and sequencing goes hand in hand with adherence. And as you know, it doesn't really matter what treatment you look at, adherence is poor with osteoporosis treatments. And what this means is that we have to be very clear when we're giving patients osteoporosis treatments, which ones we're giving based on our local guidelines. Now I'm just going to touch a little bit on osteosarcopenia. I know Dr. Jha is going to talk about it a bit more later. These are my sort of insights. So osteosarcopenia is a relationship between osteoporosis, osteopenia, and sarcopenia. And there are a lot of different definitions of sarcopenia made, but in general, they are used to identify patients who are high risk of falls and fractures, mortality, and also other poor outcomes. While the definition for osteopenia and osteoporosis are established using bone density T-scores, there is a lot of confusion about how to define sarcopenia. Everyone around the world has a sort of differential diagnosis using different measures. A recent consensus has agreed that the main thing is muscle strength, maybe muscle strength adjusted for size, but really not much value of low muscle mass in predicting the outcomes of sarcopenia, as I've listed below. Now, osteosarcopenia has often been called a dangerous duo, and it has a number of shared mechanisms. So these are pathways that both predict osteoporosis and poor bone health, but also predict sarcopenia. Excuse me. Sorry for that. And of note, there are chronic conditions like diabetes, chronic kidney disease, and chronic steroid use that predict both sarcopenia and poor bone health. And we also have the concept of osteosarcopenic obesity, and this is where you get osteosarcopenia with a high fat mass. Now, the treatments are actually unclear. We have lots of options available, from tackling inflammation, myostatin, muscle approaches, or by increasing weight-bearing exercise, as you can see here in this nice review by Taj this year. I'll just touch on two approaches and some of the caveats with this. So clearly protein intake is very important for muscle mass, and they can be both animal-based and non-animal-based. But there is a lot of protein that one needs to achieve 1.2 grams per kilogram per day. And I've listed here how many grams you have in an egg, some cheese, half a can of chickpeas, or some lentils. And that really is quite a lot of protein. However, in the UK, the issue is not simply the protein, but having patients fed. So here they looked at using dietetic assistance, and they were able to show that just feeding patients actually reduced mortality. Length of stay didn't vary, and they didn't have as much weight loss as the patients who didn't get dietetic assistance. But it does show that it's not just what they eat, but making sure they are eating. Now, another major area of uncertainty is the type of exercise patients should have. And I'm sure this will come up later. But our community has been really challenged by two large-scale studies that have shown there is no reduction in fractures if you put people into standard strength and balance classes. This is data from the United Kingdom and from the US, which clearly showed adherence was very poor, but just simply referring patients to an exercise program did not work. In fact, in the very high risk patients who had the multifactorial force production program, they actually had the highest risk of fracture. So I've talked about diet and exercise. What about medication? So vitamin D has to be used carefully, but we now have good evidence in very high cases actually have mortal fractures. I'll talk about denosumab in a bit, but all these other agents are still unclear. We have the recent TRAVERSE study, which unfortunately did not show any fracture benefit from testosterone therapy, and all of the other agents are still under investigation. In a way, denosumab has the best data. We already have done a randomized clinical trial, and a recent review has clearly shown that denosumab patients have a lower risk of falls than patients without denosumab. And this led to a study of where denosumab is working, and actually the mechanism of denosumab includes the muscle. And many muscles actually express the same receptor that denosumab touches. So there is a biological mechanism for this. And when people have looked at muscle mass and hand grip strength in the top and bottom panels, patients on denosumab seem to have more muscle and also stronger grip strength. So I'll just finish off now with the unmet need. So what is the next step for bone health assessment, and how can we bring these ideas together? So many years now we have the innovation of fracture liaison services from Team Glasgow, where patients with a fracture are identified, assessed and recommended treatment. And we have this vision of finding as many patients as possible to measure the success of a service. But we now know it's much more complicated than that. We need to find patients at very high risk and make sure they're rapidly assessed and started in treatment. And we're now developing different rapid high-risk pathways where patients can get on anabolic treatment very quickly. But doing this in itself raises a number of challenges, from funding of services, from DEXA capacity, from anabolic costs and reimbursement, and then follow-on sequencing therapy. But there is now a move where we shift from services that see large volume of patients for osteoporosis care to seeing fewer high-risk patients to prevent the same number of fractures. So what does this mean for India going forward? Well, we have to move from seeing FLS as an optional service to actually seeing bone health as a core production of a hospital healthcare system. So how good are we doing in India? And I don't know the data for this, so I went to the IOF to the fracture map, and for a population as large as India with 1.6 billion people, there are only 3 stars on the map, which is incredible. There are over 93 FLSs in the United Kingdom, and we only have a population of 60 million, a fraction of your population. But there is hope. We can now measure how to do FLS very well with published key performance indicators. We now have models where you don't need a bone expert in every hospital, but you can have one clinical lead at the regional level who can help process thousands of patients over a year. And there are now models of care where we can work as a network together to help improve outcomes for our systems. If you're interested in finding out more about secondary prevention, we've published a competency framework that's been used by orthopedic surgeons in Japan, endocrinologists in Argentina, and nurses in Spain, that you can test your own knowledge of how to be a good FLS process. And when one does look at the aging demographic, it is quite concerning. This is data from the Population Pyramid Global Survey, which says from 2025 to 2040, the population of India will go up by 10.8%. However, the proportion aged over 50 will go up by 52%. So if you think your fracture clinics are busy now, they're going to be, you probably already noticed, they're already getting busy as we speak. And this really highlights the importance of fracture management. So in summary, the steps are quite simple actually. We just have to assess and treat the right number of patients. But it's very clear that many patients are being missed and having avoidable fractures. So I'm going to finish there because I'm at my half hour. I'm happy to take questions. Of course, I'll thank my mentor, Professor Cyrus Cooper, who's doing very well, and my amazing fracture prevention team in Oxford, and also the audit team at the Royal College of Physicians. And really challenge you that we should set up systems around the country so no adult over 50 leaves a healthcare system without a bone and falls check. Thank you very much for your attention, and I'm happy to take questions.
Continuous question.
Kasim, can you hear me?
I suppose he doesn't hear on this mic. The system doesn't.
नहीं चल रहा है.
You see something from there.
वो mic चल रहा है.
Yes, can you hear me?
I can't hear anyone.
Apparently
Hello. Hello. Can you hear it now?
So you can sit there, that would be better.
I'm so sorry. Hi, Kaushik.
Hi, can you hear me?
Can you hear me?
Yes, yes.
I can't hear you. technology. I should have seen the Taj Mahal with you this morning, Kaushik. I'm very upset with. Oh, I can hear you.
Oh, okay.
Yeah, I can.
So I'll hand you over to Dr. Chaturvedi.
Hello. And I just want to thank you all again for this very kind introduction.
Thank you, Dr. Carson. Now, we are opening for question and answer session. Dr. Arun Kapoor wants to ask a question.
Please.
Dr. Carson, do you hear me?
Yes, I can hear you clearly.
Well, that was exhaustive, that was long, that was eye-opening, and a wonderful discourse that you have given. I suppose you must be pretty well tired by now. But when having a lot of knowledge, that brings in a lot of confusion. So we have been enlightened. Thank you for that. But well, could you bring us out very clearly, below 50, over 50? If a guy has a T-score below 2.5, that is, you are heading for osteoporosis, what would you exactly be the line of treatment regarding all these abaloparatide, teriparatides, this alendronate acid, alendronate, denosumab, or rosasumab? Very clearly, in a very few sentences, what would be your preferred choice in indication number 1, 2, 3? Your drug of choice.
So my choice for number 1 would be romosozumab, and the reason is it will reduce non-vertebral fractures within 12 months. If for some reason they couldn't have romosozumab because of cardiovascular concerns, my next agent would be probably abaloparatide or teriparatide. If the patient could not have any anabolics because of reimbursement concerns or other reasons, then you have the choice between zeledronate or denosumab.
Okay, thank you.
Not at all.
Well, Dr. Jha here, very illuminating talk. You talked about a study in which romosozumab has been given for only 3 months, followed by denosumab. And you said this can be very valuable, economically speaking as well, and the results are comparative. So would you advocate 12 months use, or you will like to switch after 3 months to denosumab?
At the moment, and that's why I love medicine, because everything changes, at the moment I would definitely advocate 12 months therapy. The reason is they are now doing a large fracture study. And although the BMD results should reduce fractures, we have to see if you get the same fracture reduction. Because not all of the benefits of fracture reduction from romosozumab will be captured by DEXA. DEXA is really good at predicting fractures, but as you know, it's not a perfect tool. So I would say this is exciting, but it's not enough to change practice yet. And if we really are good clinicians, we should stick with 12 months. What we can do in 3 months. And these unanswered questions are really there for us to watch the space rather than make a change at the moment. I wanted to share it with you because other people know about the study, and I want you to be as up to date as possible, but be aware it's not changing practice at the moment.
Right. And regarding the black box warning of romosozumab, we are all aware that we had a black box warning with teriparatide as well, which has been removed now. So, as far as the black box warning of
romosozumab,
right? Okay. Black box warning of romosozumab.
I can't hear anything. Someone said about the black box warning with teriparatide.
Okay. Am I still audible? No.
Hello.
Can you hear me still?
Yes, I can hear you.
I can hear you again.
Right. So I was talking about black box warning of teriparatide does not stay now. It has been removed. Similarly, there are studies now where romosozumab can be administered safely even in patient with cardiac event in the last year. You must be aware of some studies.
So I'm not aware of any published study because the of a large scale, there have always been maybe some reports. So the big reassurance is 1.3 million people have now had romosozumab. There has been a big difference in the cardiovascular risk between countries. So in America, it's only a cardiovascular event in the last year, whereas in Europe, it's a lifelong risk. So if you've ever had a heart attack or stroke, then you cannot have romosozumab. Now, what's reassuring is that over the 1.3 million, no one has changed the American guideline. So the American guideline that within 1 year is enough seems to be very reassuring. And to be honest, there are thousands of patients who've had a fracture and haven't had a heart attack in the last year who would be eligible for treatment. The only area of concern, Dr. Jha, are those patients with severe renal failure.
Right.
Those patients have extremely high fracture risk. Often they're not on dialysis, and the bisphosphonates and the denosumab may either worsen their kidney function or cause severe hypocalcemia. But the current trials really haven't helped us to understand in the setting of severe renal failure, so a creatinine clearance of less than 30 or maybe less than 20, is romosozumab safe? And for me, that's still unanswered. There are some dialysis studies, but dialysis patients are very small, and we see many more patients who don't have dialysis with poor kidney function.
Right. Talking about romosozumab again, we are giving 2 shots every month.
Yeah.
If the body weight is this, there are trials in which half the dose has been used. Would you advocate in patients of smaller body weight, which Asians are, only single shot will help or serve the purpose?
I would need to see those studies. It's the same question as the leader study with 3 months. We have to be careful because there have, as you know, been osteoporosis treatments that have been tested that reduce spine fractures but not hip fractures. So I would be cautious of going outside of the recommended dosing, and I do not dose adjust my patients by body weight. Yes, and I have given to very low body weight people. The reason to dose adjust, I suppose you would be concerned, is hypocalcemia, but we have not seen that in our population with low body weight.
Dr. Sarika, you will be asking next question.
Good evening, sir. As a part of a preventive protocol or to detect the first
there's no batteries in the machine. I'll send you some Duracell batteries from England. Kaushik should have some.
Go that side, so you'll be able to.
Does that work?
Hello.
Oh, hello.
Yeah. So, as a part of a preventive protocol or as a part of diagnosing the first vertebral fracture, which diagnostic tool will you like to advise to the vast population of India? DEXA or something else?
Yeah, so that's a very good question. So DEXA availability won't be the same as X-rays, and to be honest, a good standing, and it has to be a standing lateral X-ray, will pick up the moderate or severe fractures. MRI obviously will pick up the recency with the edema. So just be careful with an acute fracture where the patient is bedbound. Taking a lying X-ray, sometimes you won't see the deformity. So that's how you pick up the new fractures, but there you have a problem, and then we're trying not to X-ray everyone with acute back pain. Another very fruitful route is look at your CT scans. If you're in a big teaching hospital or a big district general hospital with a CT scanner, your CT scanner will be pouring out scans with vertebral fractures that nobody's doing anything about. And the new AI technologies will not only pick out the vertebral fracture, but they'll also look at the density of the spine and give you an estimated T-score. So you have in essence, already in your hospital system, a list of patients with vertebral fractures and their DEXA for free after you take into account the cost of the AI. And that is going to be absolutely revolutionary because AI will just take over and it will almost be fracture liaison services will start with AI and then do trauma clinics because it's so fast to find them. And when the AI takes 3 seconds to find a vertebral fracture, that's faster than anyone. I can't even do that. So that's the future.
Thank you very much, Professor Javed, for the excellent and highly relevant presentation. We are grateful that you could join us virtually and share your expertise with Orthopedic Fraternity of Agra. We shall now take, thank you again, Professor Javed. If your schedule permits, we would be honored if you could remain connected for the later panel discussion. Or we can message you just after this lecture of Dr. Kaushik Chaudhary.
He has said he will be there.
Okay, you want to stay there. Thank you.
As you don't have to, but you're very welcome to.
Okay, do you want me to stay for the panel discussion?
That
or
might
will
be an idea. Yeah. So if you want to zone out and come back again, we will message you. We'll message you. We'll message you. And make sure England wins tonight.
Right, thank you. Thank you, Dr. Kaushik.
Sir, just a second. You can download, you can open the question from the QR code which may have been given, and I have sent you the message that will be interactive session which Dr. Kaushik Chaudhary will be taken with, he will be asking question and audience poll in that. Thank you.
So if you want to come back in half an hour roughly.
Yep, I'll do that.
Thank you.
Thank you, Cal.
Right. So friends, you have just seen the electrifying personality, Dr. Kaushik Chaudhary. He is basically a rheumatologist working in Coventry, UK. He is the head of the Department of Osteoporosis and lead at the University Hospital. He is involved with a number of UK and European organizations related to rheumatology, particularly related to education and training. He is also the president of rheumatology section of the Brussels-based European Union of Medical Specialists. Over and above, all of us know EULAR, and he is a member of Council of EULAR. Dr. Kaushik Chaudhary, the stage is yours now. We are happy you are physically present. Thank you.
Thank you for your introduction, Dr. Jha and colleagues from Agra.